Hi, everybody. My name is Arunwan Pritipan. As a president of Asian Pediatric Pulmonology Society, or APS, and the president of the Thai Society of Pediatric Respiratory and Critical Care Medicine, I would like to welcome you all to the first APPS Grand Round. After the 8th APPS annual meeting in Padang, Indonesia last year, the executive member of APPS have come to consensus to initiate APPS Grand Round via Zoom on a monthly basis on the last Friday of the month. This will provide the platform for sharing knowledge and experience among Asian pediatric pulmonologists, which hopefully will lead to the cooperation and support between us in the future. This activity is totally voluntary. Today, we are lucky to have Associate Professor Haruthai Kamalaporn as our moderator. She is a pediatric pulmonologist working at Ramathibodi Hospital, Mahidol University, Bangkok, Thailand. She obtained subboard from Thailand and have further training at Toronto for Sick Children, Canada. So I will give a microphone to her.
Good afternoon and good evening to everyone around the world. Today is my pleasure to be a moderator of the first APPS Grand Round. May I introduce you to our panelists? The first one is Dr. Daniel Ng. He is from Hong Kong. He is the honorary consultant at Department of Pediatrics, Hong Kong Sanatorium Hospital. And the next one is Associate Professor Hussein Al-Qaidi. Hussein is a pediatric interventional pulmonologist and intensivist. He is a director of the Pediatric Interventional Pulmonology Division, Shiraz University Medical Science in Oman. And the last one is Associate Professor Hussein, Ashkan. He is from Iran. Okay, so now welcome our panelists. And the presenter is Dr. Kanok Gan. She is a doctor from Chiang Mai University. She is graduated from the Hospital for Sick Children or Sick Kids of Toronto in Canada, just like me. So please, Dr. Kanok Gan, please proceed to your case presentation.
Thank you, Dr. Haruthai. Let me show my slide. Okay, let's start with the case. Okay, he is a 5-month-old male infant. He was referred to our tertiary care due to dyspnea after breastfeeding and prolonged oxygen therapy requirements for 2 months prior to admission. 2 months prior to admission, his mom noticed that he had intercostal and subcostal retractions for 2 weeks. And he also had tachypnea, especially after breastfeeding. He had no either fever or previous URI symptoms before. He had no history of reflux, and he has no neonatal illness before admission. So his mom brought him to a private hospital. He looks irritable and tachypnic. He had no fever. On his physical examination, he had 5 crepitations both lung, and chest X-ray is shown in the slide. At that time, the impression is pneumonia. Given that he had desaturation on room air, oxygen cannula 3 liters per min was prescribed, as well as NPO and IV fluid. After that, he was referred to another hospital, primary care hospital. At the primary care hospital, he still looked progressive dyspnea and significant desaturation. He had low-grade fever. On his physical examination, he had nasopharynx, 5 crepitations on both lungs. Significant subcostal and intercostal retractions were observed. The impression was severe pneumonia. He had desaturation even though he on oxygen cannula 3 liters per minute. So mask with bag 10 liters per minute was tried, but he still dyspneic. So he was intubated and septic workup was done. The maximal mechanical ventilator setting was shown in the slide. The next slide, I will show the chest X-ray after intubation. This is the chest X-ray at Provincial Hospital after intubation. For the additional information, he was born at 36 weeks due to previous CSAR via cesarean section. He had no neonatal respiratory distress or complication after birth. Interestingly, he had poor weight and height gain, which is shown in the growth curve. He had no significant history of allergy, cystic fibrosis, and TB contact in his family. During his admission in Provincial Hospital, he was diagnosed as severe pneumonia once and hospital-acquired pneumonia for 2 times. However, the septic workup were negative. Currently, GERD medication was prescribed and he was on high-flow nasal cannula. The next slide, I will show his clinical lab and his chest X-ray. He is a male infant with still dyspnea. He had no fever, and his oxygen saturation room air is around 85, and he was on high flow nasal cannula with flow 10 liters per minute and FiO2 0.8 to keep up his oxygen saturation. And he still had poor weight gain and height is still below 3rd percentile. On his physical examination, he still had tachypnea, like shallow and fast breathing. Significant subcostal and intercostal retraction were observed, and he also had bilateral thigh crepitations. No cupping of finger were observed. Otherwise, were normal. This is the lab and chest X-ray. It is for his capillary blood gas, electrolyte, and immunoglobulin, and other laboratory investigations were normal.
Okay, thanks, Kanokar. It's quite a lot of information, and I can tell that I can see that it's such a difficult case that switched from hospital to hospital. So right now you are the 3rd hospital already, right? So may I ask one of the panelists to summarize the pertinent finding and summarize the problems to lead the audience go to focus on the problems. So may I ask Ashkan, may I ask you, please?
As the history give us more information about this patient at this step, I can summarize all the finding and go proceed with the differential diagnosis. We had a 5-month-old boy with progressive dyspnea, cough, oxygen dependency, chest disconformation that proceed with several hospital admission and also the referrals from the hospital to other hospital. And the end result was the failure to treat and weight loss. On the examination, we can find that the oxygen of the patient could be improved by the supplement oxygen. So we can conclude that there was no shunt or severe fibrosis or remodeling, as the patient already was in earlier stage. The important thing is the chest X-ray. We can see the progressive bilateral or symmetrical, and generalized alveolar pattern and grain glass opacities. There were no clapping, no abnormal syndrome finding, no choking after feeding, and I think at this stage there was normal echo. So all of these can conclude that we have a patient with progressive dyspnea, coughing, oxygen dependency, and this is progressive scenario. And so we can conclude one of the main problem is chronic lung disease, and mostly the children interstitial lung disease. Please, next. Okay, in the next slide, in the next slide, I summarize the most important differential diagnosis for this patient at this stage of the history taking. We should thinking about gastroesophageal reflux disease with microaspiration and aerodigestive problems. Pulmonary interstitial glucogenosis or neuroectodermal cell hyperplasia of infancy and genetic disorder of surfactant metabolism should be taught. Also, we have to thinking about the cystic fibrosis, hemosiderosis, infections, and some problem after the infections like bronchiolitis obliterans, hypersensitivity pneumonitis, anti-GBM antibody disease, lymphoproliferative disorder, pediatric severe combined immunodeficiency or any other immunodeficiency states, and cardiac problem like total anomalous pulmonary venous connection and syndromes like Down syndrome.
So Ashkan, these are the whole set of the differential diagnosis, which is quite kind of serious and difficult diseases. And if I ask you, is that you make it in the order, the first order, is that mentioned mean that you think about it the most and then
Yes.
respectively? Okay, perfect. So you think about GERD or microaspiration first, and then maybe about the pulmonary interstitial
lung diseases.
Yep. Okay. And then CF going to be the third possibility. Okay, thanks. Is there any comments from any panelists? Daniel, do you have any more comments, please?
Yeah, I think important to look for aspirations. And again, the next slide. Okay, next. So I think someone who is on chronic respiratory insufficiency, respiratory distress, and then acute deterioration, one have to think about aspiration. Aspiration could be either from reflux from the stomach or aspiration during oral feeding. So it's important that when the patient is intubated, we perform either a bronchoscopic directed lavage of the bronchial alveoli, or we do a modified BAL, meaning that we put a suction catheter down the ET tube blindly until we meet resistance, and we inject some normal saline, 5 ml, and then aspirate out for lipid latent macrophage, which is very helpful to confirm the diagnosis of aspiration either from reflux from the stomach or aspiration during oral feeding. Next slide, please. So I just take the time to ask a wide audience that we can do a quantification of the lipid latent alveolar macrophage, the LLAM score. We ask a pathologist to count 900 cells and score them individually. The fat latent macrophage is red in color, so you give them a score: 1 for 1/4, 2 for half, 3 for 3/4, and 4 for whole cells. If the count, the LLAM score is more than 200, it's highly suggestive of aspiration, and it could be aspiration from the stomach, aspiration during swallowing. So I think it's important for audience to remember the aspiration could either be the etiology of the chronic lung disease or that aggravate the already existing lung disease. Thank you, Habitat.
So Daniel, you mean that it's not only to see if the lipid-laden macrophage present or not, right? You need the quantitative, actually, right? You need
Yes,
to see. Yeah. Okay.
Yes,
Perfect.
very important.
Yep. Thank you. That's an interesting point. Okay. So we may proceed, Kanokkarn. Yeah, so I would like to ask the audience, because right now we have some idea. We would like to ask you, what would be your next step of investigation? Right now, think about you are at the tertiary care hospital already, and then these are the whole set of the investigation. You can choose only one choice, please. Right now we have 320 audience, so please do so. We're gonna wait a bit. Right now we got, if we reach about maybe 70% of the participant votes, and then we stop. Yeah. Okay. Oh, not increase in number. Okay, so maybe we stop here. So right now, the vote result, I hope you guys can see it. So most of the audience, 67% of the participants who vote, choose the high resolution CT scan, and followed by the bronchoscopy and the lung biopsy. What would be your next step? And actually, do you agree with the audience that we're gonna do high resolution CT scan? So Kanokkarn, you may show us that what exactly you do at your hospital.
Of course. And this is for HRCT of chest. I would like to show you the upper part, middle part, and lower part of HRCT of chest of this patient.
Okay, so maybe one of the panelists can help us interpret and just guide the audience how to interpret this CT scan. So may I ask Ashkan, please?
Thank you very much. Would you please, I can share my screen. I choose one of the cut of this high resolution CT scan that done without the contrast. At this point, you can see several things. The most common things is decreased lung volume by side. So this implies this is the restrictive lung disease. The second thing is mild pectus excavatum. You can measure it with the, excuse me, if my eye, do you see my
Pointer, yes.
pointer?
We do.
Yes,
Yes, we do.
This is the window, the orange window. You can see the pectus excavatum here. And when we measure the Haler index, we can find that there are also the mild restrictive pulmonary ventilation disorder. How we can use the Haler index for the audience? We can measure the AP from the posterior aspect of the sternum to the vertebra and the transverse of the thoracic inlets at the maximum size, and this ratio from the transverse to this vertical should be less than 2. At this time, you can see this is more than 2. So this is that imply that the patient suffer from the some type of the dyspnea, progressive dyspnea, and maybe this is the lung volume decreasing, and also we can see like this problem in the neuromuscular disorder. Another thing, so we can see the generalized haziness of the lung. We can call this the Graham glass opacity attenuation. which you can see this is a bilateral GGOs, and this is too important from the symmetrical to the unilateral GGOs. So I can proceed in the next slide of how we can approach with this problem. Another thing, we can see the microcyst with the very clear and a small cyst around the sometimes in here I can show with the arrow here, and also in other part of the line you can see the small cyst, mostly in the the peripheral. And
Like
another thing
subdural.
is,
Okay.
yes, and this another thing is fibrotic bond. You can see this is a large arrow. You can show this is the show you the fibrotic bond and rebounding and remodeling of the lung started to be happen. But we could not be able to, because deplugging all the airway is patent, no mosaic attenuation to suggest a small airway disease or hypersensitivity problems or pneumonia, no focal area of consolidation to suggest bronchiolitis obliterans, no ill-defined central lobular nodules or honeycomb formation to suggest hypersensitivity pneumonitis, no localized or gravity-dependent consolidation and central lobular nodule to suggest aspiration syndrome, and no heterogeneous GGOs to suggest NKX2-1 genes, NEHI problem, or pulmonary interstitial glucogenosis. So as you can see, we can see this CT scan and rule out several things and rule in some other things. For approaching this type of CT scan, please start with the lung volume. If the lung volume is high, normal, or low, proceed to step 2. Okay, we start with high lung volume. This can be seen in the filament A mutation and neuroectodermal cell hyperplasia of the infancy. As you can see, there are no more granulous opacity and also absence of disease in the filament A mutation and some cysts in the neuroectodermal cell hyperplasia of the infancy. If we have facing with the normal lung volume, there are the most common maybe trisomy 21. As you can see, there is no more, I mean this symmetrical and general granulous opacity, not localized. So we could not be able to see the granulous generalized pattern in the trisomy 21. And also we have a cyst formation, mostly in the fissures. And other problems is NKX2-1 gene that we can call brain lung thyroid disease that you can see here. We can have a normal lung volume, but we have a generalized granulous opacities. And the last one is low lung volume, pulmonary hypoplasia with absence any generalized granulous opacity, no any cyst, and surfactants deficiency problems. You can see the presence of the generalized granulous opacity, and also you can see some cyst and septal thickening. As you can see in this slide, with your facing with this that the cutoff CT, as I showed you before for this patient, you are facing with the low lung volume and granulous opacity as a general. So you can simply decide that the most common problem may be the surfactant insufficiency. Thank you very much, and please go ahead.
Oh, that's brilliant, Ashkan. Yeah, so I think the audience made the right choice about their investigation because most of us choose the high resolution CT scan and just realize that how useful of the high resolution CT scan that you can like cut off your differential diagnosis, because if you remember, you have the whole list of the disease in your first differential diagnosis. And if only the high resolution CT scan can have very informative data, and then you cut off or you rule out many disease. So now you focus on the surfactant deficiency. So let's see. So Kanokkarn, you have the answer, right? So let's proceed.
This is for the this patient also have a flexible bronchoscope with BAL done as well. The finding shows no structural abnormalities, no laryngomalacia, no tracheobronchomalacia, and BAL cell count and differential was shown in the slide. No organism seen in BAL, and bacterial and fungus culture were negative. For BAL cytology, reported that clear fluid and negative for malignancy, no organism seen, and no evidence of hemosiderin-laden macrophage and lipid-laden macrophage seen. For the ECG and echocardiogram were normal.
Yeah, we did it as the Dr. Tianchai Vanalai suggested, but we may do it later. And the question is from the audience is, was the patient still intubated when you perform bronchoscopy? Dr. Kanokkarn, can you answer this question? Is the patient intubated while doing the bronchoscopy?
At the provincial hospital, the bronchoscopy is unavailable for the primary care hospital. When this patient was referred to our tertiary care, this patient was on high flow nasal cannula.
So the patient was intubated at the beginning, and then they wean off the oxygen to high flow. They extubated already when they sent it to you, right? And then
Yes.
And comment from Professor Arunwan at this time, for the high resolution CT, it would be more helpful to control the ventilation. Yeah. Okay. So they may intubate it, the patient when they do their high resolution CT, right, Kanokkarn?
Yes.
They control the breath with their intubation, right?
Yes. With LMA by anesthesiologist.
Okay. The laryngeal mask. Okay. And then so please move on. So we did the bronchoscopy and then echo and ECG, and then please next. Yeah. So maybe one of the panelists can make the interesting point at this time, because we have a set of investigations already. So Ashkan, please. You may unmute yourself.
Okay.
Yes, please. Thank you.
Can you hear me?
Yes, clear.
Okay. So there is some points I wrote here, that at this level, the interstitial lung disease most frequent diagnosis in the first year of the life, and pulmonary interstitial glycogenosis, or NHIE, and genetic disorder of surfactant metabolism can be taught as the part of the interstitial lung disease, especially in the young infant. Several problems like tachypnea and progressive dyspnea are too common, especially dry cough. And some of these patients come from to the referral centers and change the hospital too much. Younger infant manifested retraction, difficulty in feeding, and diaphoresis with feeding. It's too important, which may result from anorexia, difficulty in feeding, and increased energy expenditure from the increased work of breathing and crying. But At this level, in the interstitial lung disease, we have no more fever and sometimes wheezing. We are facing with the crackle mostly in the general crackles we can hear from the chest auscultation. And it's approximately near 20% of the patient only have fever and the wheezing together.
Okay, thanks. So,
Welcome.
yes. So may I ask, Hussein or Daniel, that remember this child has been diagnosed as pneumonia or or even ARDS at some point before referred to Kanok Hospital. And do you agree that, or you think something differently rather than pneumonia? Because actually, I remember that Kanok presents that the child has no fever and there is no bacterial culture growth during their investigation. So may I ask, Hussein, do you agree that this may be about the misdiagnosis or something that the patient, the doctor in the first hospital, they may not know because this is kind of the rare disease that we are talking about? Could you please make a comment on that, Hussein?
Yeah, thank you very much. Well, it's always in the beginning when these patients present to us, it's not easy to differentiate, and especially early on when the infant was only 2 or 3 months of age. Fasting is fast, so infection is definitely something we need to rule out, and sometimes even viral infection is higher on the list than bacteria, and viral, as you know, is not as easy as bacterial to diagnose. So treating the infection, ruling out aspiration pneumonia and others is more important. But if the patient progressively continue to be tachypnic and needing oxygen, this is then when we start to think about other more rare differential diagnosis. So I agree with their approach, and I think in a primary or health system, sending to secondary and then secondary also unable to diagnose sending to tertiary where the patient will have CT scan, bronchoscopy, it was rightly done.
Yes, thank you very much. So we have the question from the audience, Dr. Mahesh Babu. He asks about what was the color of the BAL which was returned. Is that milky? Kanok, could you please answer that? Is it the milky fluid?
This fluid BAL is clear, no redness and no milky appearance.
Okay. Okay, thanks everyone. Okay, we may proceed. Kanok, please. Yeah, so at this point, to prove that the child has the ILD or not, yeah, Ashkan, you may have some more comments about this, right?
Yes, I first discuss about how we can approach from the CT scan of this patient to the right diagnosis. But sometimes mostly in the rare diseases, we need the genetic studies, especially for the children interstitial lung disease. We have to choose the less invasive procedure because this patient suffer from the hypoxia and don't tolerate something like anesthesia, lung biopsy as the first step. So nowadays, the genetic studies and genetic consulting available in more and much more countries. The best way is a whole genome sequencing and next generation sequencing also. We can investigate the gene lengths for the surfactant production mutation, like surfactant B, C, or cassette, or ABCA3, or NKX2.1, or for surfactant catabolism, like CSF2FA or RB or SLC7A7. All of this is the most common problem. All is rare, but in the rare, this mentioned gene sequencing mutation, I choose the more common mutation. But the point is, in the two sentences below, testing for the surfactant C and cassette ABCA3 mutation should be considered in infants and children with exhibits digital clubbing, diffuse granulous opacity, and reticular pattern and changes in their HRCT. And if there are no familiar history of chronic lung disease, this is too much important for us if the patient suffer from the familiar history, positive history of the chronic lung disease or family history. But if the patient suffer from the unexplained neonatal respiratory distress, and if the family history is not understand or not positive, we can choose the more testing like is surfactant B and again the cassette ABCA3. As you know, the surfactant B is too lethal, and the child quickly go expire and pass away after the several months. This is too much severe problem. But surfactant C and some mutation of its cassette have some good effect, and the patient can go forward to the next years of their life. Thank you very much.
Okay, thanks. That's a very good point mentioned. And but having said that, you recommend to do the genetic testing. Having said that, our audience, or even in Thailand, in some hospital, it's very difficult to do the genetic testing, or in some place around the world may not have been available genetic testing. So even have it, the result usually takes few months to come back, right? So while waiting for the genetic result, how would you treat this patient? Do you have to wait until the result come back, or you can do something? May I ask Daniel, please?
Thank you. Next slide, please. I think it's important for us to remember that as a clinician, even without a definitive diagnosis, we need to support the patient. So important wide respiratory support, as shown in this case, an appropriate heated humidified high flow or bilevel to normalize. It's important to normalize the oxygen and normalize the carbon dioxide. So it's important to know that the cap gas show normal capnia. So the treatment would be more effective with heated humidified high flow. You probably do not need a bilevel with that normal capnia. And so also important, remember the energy expenditure of a respiratory distressed child is very high. So you need to provide enough calorie and protein to maintain a normal growth and metabolism. And at the same time, prevent aspiration during swallowing or during reflux. So I would like to share with you a video about cervical auscultation to define dysfunctional swallowing. Traditionally, we can use VFSS, video fluoroscopic examination of swallowing, but a lot of times not available in a lot of centers in Asia, and also very expensive. So cervical auscultation is to assess the sucking, swallowing reflex in coordination with breathing, which is an important clinical pathway that I would like to share with you.
Okay, go ahead.
So that goes the microphone, hear the breathing, the sucking, the swallowing. If that is coordinated, there will be overlap. You know that style. I'll stop sharing.
Wow, interesting. Daniel, could you please explain what are you doing there? Yeah.
Yes. I'll stop sharing first. What is The video is done by my colleague in Seattle, Robin Glass, who's an occupational therapist. So this technique is well known to allow us to know whether it's a synchronized sucking, swallowing, and breathing, so that this airway digestion is all go to proper pathway. The air go into the lung, the milk go into esophagus. And this is a cheap way to do the VFSS, to assess if there are any dysfunctional swallowing. So for all my colleagues in Asia, you may like to learn more about cervical auscultation. It's not difficult for any doctors to acquire the skill.
Wow, interesting. Do you have any publication about this or somewhere that we can read about?
Yes, you should Google Robin Glass, who's the author, and she published a lot on this.
Wow, interesting. Thanks, Daniel. Okay, so right now, there is some question in the chat box asking Dr. Kanokkarn about have you done the PAS stain, the periodic acid shift stain from the BAL fluid? Have you do the specific stain like the PAS?
Oh, yes, I think about that as well, but unfortunately, in our institute, at that time, PAS and electron microscopic for BAL is not available.
Okay. Okay, so there is some comments about the treatment in the chat box, but we will go back to that for sure. Okay, so right now, Kanokkarn, could you please proceed to the result of the genetic testing, and then we gonna do some treatment afterward.
Okay, luckily we have already sent the genetic whole genome sequencing, but it takes quite 3 to 4 months to get the result. And the result what shows the heterogeneous missense variant in the SFTPC gene, which is compatible with surfactant protein C deficiency.
Okay, so now this is the answer of your case. Okay, so but we don't stop here. We're gonna go forward to the treatment. Okay, so so about this, can we just do some words about if the patient has a surfactant protein C deficiency? Before asking the panelists, may I ask the audience first to do some words about the treatment? So we're gonna do the poll again, that to treat the patient with surfactant protein deficiency. So what would be your drug of choice? We have 5 choices: house methylprednisolone, oral prednisolone, hydroxychloroquine, azathioprine, and cyclophosphamide. This is a single choice, please. Our audience is very interactive, voting and sending some comments in the chat box. If we cannot perform genetic testing or are still waiting, what the management? Yeah, so so Daniel answered part of that already. And okay, so right now we have 150 and more of voting. Most of the participants right now choose pulse methylprednisolone for 62% and more. Okay, followed by the oral prednisolone, as you can see that, and 11% choose hydroxychloroquine. Yes, yeah, in the chat box, oral prednisolone to be chosen as well, and few of the audience choose azathioprine and cyclophosphamide. Okay, we might end the poll now. Thank you. Thanks everyone for your participation. So so may I ask Hussein, so what should you do if you see this patient, and what should be approach for the treatment, please?
Yeah, okay. Can we see the next slides? So the genetic of surfactant dysfunction is actually has been described quite a while ago, and in this table, I know it's not very clear, but you can always find such a table in review articles where you have a specific description of each of the four known surfactant protein deficiency and how do they present in differentiating. Next slide. Move next, please. So again, just going back to the management, as already mentioned by Daniel, first we have to be to support this patient. They are hypoxemic. They have to be on oxygen. They have failure to thrive. We have to make sure that they are given good nutritional support. Also, don't forget they are prone to have other infections. So influenza vaccination, annual influenza vaccination, also vaccination against other respiratory pathogens are very important in the management. Then we move to the specific management, pharmacological. Let's see the next slide, please.
Next, please. Yes, thank you.
Yeah, so until now, we don't have any specific treatment for these patients, but people, they treat this patient with methylprednisolone, initially 10 to 13 milligram per kg for 3 days in a monthly intervals until they get better improvement, and then you space it or change it to oral prednisolone in the dose of 1 to 2 milligram per kg. Some other centers, especially if they are highly experienced, they either switch from methylprednisolone to hydrochloroquine or start with this based on their experience. Other cytotoxic drugs such as azathioprine, cyclophosphamide, and cyclosporine are all being used. And because of the rarity of the disease, they really need a specific experience, but mostly people will start with methylprednisolone. Markaloids, azithromycin are also been used as an anti-inflammatory. Of course, many of these patients may benefit from lung transplantation, but as you know that when they present early on, they may not survive long enough to get transplantation.
Thanks, Hussein. Okay, is there any more comments on the treatment from Daniel or Ashkan before Kanokarn tell us that what has been done?
I think
Daniel?
vaccination. Yeah, I think vaccination is very important, especially as well as antibody. I think in Hong Kong and in Thailand, do you have a lot of RSV in Thailand?
Kanokarn?
Oh, yes. At that time, at this time, we didn't have the RSV vaccination or antibody for RSV yet, but RSV season is quite a lot in Thailand.
Yeah, I think it's important for us to, in Asia, to establish support to provide RSV antibody, the pyralizumab, to this kind of patient. Otherwise, they will tip the balance and patient may succumb from RSV infection.
Yeah, the pyralizumab is coming soon. Yeah, as of this year. Yeah, they just passed the FDA approved in Thailand. Yeah, and we will have it available soon. Yeah, and you mentioned that this kind of chronic lung disease should receive that, right? Yeah, but it's
Yes.
still quite expensive in our country. But yeah, I think Kanokarn, we are looking forward to have that pyralizumab soon. Okay, thank you.
Yes.
And so, Kanokarn, could you please proceed to your management first, and then we're gonna respond to the comments in the chat box, which is right now more than 10 comments already. Yep. You may
Okay.
go first
This slide
about, yeah, sure.
Okay. This slide will show the management for this patient in real life. At the first time primary care hospital, this patient received the intubation and on mechanical ventilation. And after that, he was weaning off and on high flow nasal cannula. The diuretic IV was prescribed in the short period. And at the primary care hospital also prescribed the proton pump inhibitor as well before they refer to our tertiary care hospital. At the first time, at the beginning, we continue high flow nasal cannula and PPI because GERD could not be ruled out. But we add oral diuretic drug because we treat this patient as chronic lung disease. And we also see that this patient have failure to thrive. So we consult the nutrition to improve nutrition to catch up his weight and height. For the summary for the management in our tertiary care hospital, basic lab workup was done, as well as bronchoscopic with BAL. At that time, we continue high flow nasal cannula, oral diuretic drug, and improved nutrition. We continue proton pump inhibitor until the bronchoscopic with BAL results show no evidence of lipid-laden macrophage. So we stop PPI. And after that, around 1 to 2 weeks after bronchoscopic with BAL, the patient developed wheezing and he showed fair air entry, and he also had hyperinflation on chest x-ray. So we have tried bronchodilator, and he also respond to bronchodilator as well. So at that time, we suspected that he had bronchospasm. So we continued salbutamol and budesonide nebulization after that. After that, we also order the HRCT of chest, and HRCT of chest show diffuse ground glass appearance. So we differential diagnosis of surfactant deficiency as well. So we send the genetic workup, but unfortunately, genetic workup quite takes a long time to get the result. At that time, we think that the most likely in this patient diagnosis is quite be surfactant deficiency. So we treat this patient with methylprednisolone, hydroxychloroquine, and azithromycin at that time until while waiting for the genetic result. After we treat with methylprednisolone, we can wean off the high flow nasal cannula of FiO2. We can decrease the FiO2 from 0.8 to 0.6, 0.4. Luckily, at that time, 4 months later, the genetic results show that the patient compatible with surfactant protein deficiency, and we still continue the medication. And for this time, this patient can wean off the high flow nasal cannula and just on oxygen cannula of 3 liters per minute via nasal cannula. And this is the progression of patient. You can see that we prescribe methylprednisolone for 6 cycles. Each of chest X-ray, you can see the improvement of respiratory rate and oxygen saturation, and we can wean off the flow of high flow nasal cannula and FiO2. And this is the 4 to 6 cycle of methylprednisolone. That you can see the improvement of tachypnea and oxygen saturation as well. At this point, recently the patient have the OPD follow-up in the December. Currently, he is on oxygen cannula 1 liter per minute via nasal cannula. and his weight and height is better. His chest X-ray is improved as well.
Okay, so right now the patient's still on oxygen cannula, a liter per minute, right?
Yes.
Okay, but things seems to be improved, as you can see from the weight and height. So right now we have many comments in the chat box. Lots of comments. The question is about what is the minimum age at which hydroxychloroquine can be given? Hussein, could you please respond to that? The minimum age of hydroxychloroquine that should be given.
Actually, I myself never used it, and I don't have personal experience. So whatever I presented into today's talk was related to my reading. So if anyone else in the panel have experience or the audience, maybe they can inform us.
Okay, Daniel, what about you?
So I think one of the reasons is the impact on the retinal nerve. So it's important for the ophthalmologist to assess the child before using it and then monitor regularly, and especially for long-term use. But I think it can be used in this young age with this close monitoring.
Okay. Okay. So we can use in infancy period as well in Thailand. Okay. So
And
the next, yes.
It can also have ophthalmic examination follow-up as well.
Okay. For a side effect of their color blindness, right? Okay.
Yes.
And is there any specific reason for limit feeding over 30 minutes? What about the infusional feeding for 1 hour? That's the question.
Yeah, I think
Yes.
the feeding time is I think more than 30 minutes is really too much exertion. So we do not want to, because feed, suck, and swallow is an exercise. So if more than 30 minutes, it means that the child got exercise intolerance. So before he or she decompensate and aspirate, we should stop. And also, you go beyond 30 minutes, you will be making it very unpleasant for the baby. So most of the feeding specialists and myself also would not prolong the feeding to more than 30 minutes oral. So and not of course, if oral feeding is not enough for anabolism, then we can give a nocturnal milk drip as a supplement.
Okay, thank you. Next question. If planned for methylpred pulse monthly, should we give the low dose oral maintenance steroid as well? Is there any panelist who would like to respond to this question about oral pred instead of the methylpred?
But so the question is the pulse methal being not the first choice, but oral? Is that the question?
Yeah, should we give low dose oral maintenance steroid as well during, I mean, I'm not sure about the question, but maybe they mentioned about methylpred monthly, and then in between, maybe in between the months, should we give oral low dose maintenance dose steroid as well, or we don't need it?
With this, when you give a huge dose of methylprednisolone, you do not need to give during the time off. You just pulse them, and there's no need for low dose in between.
Okay, so just pulse it monthly. But
Yes.
if you gonna use the oral pred, you don't need the methylpred maybe, right?
Yes.
You choose one. Yeah, you choose only one.
Yes.
Okay. There is the comment from Dr. Salim Ismail. I had a similar case 20 years back, and he had biopsy at Great Ormond Street, London. And the child is very well on hydroxychloroquine. Yes. Yeah. Okay. That's a good comment. Yeah, experience. Yeah. There is a question about the pulmonary hypertension. Does this child have pulmonary hypertension? Dr. Kanokar.
This patient
Yes.
Can you hear me? Oh, okay. This patient has clinical, but just his clinical of pulmonary hypertension when he is crying or suctioning. He had some cyanosis, but the echo and ECG show negative result.
Yeah, there is a comment that they need to follow on the echo periodically and careful cardiac exam. Yeah, just a comment for your follow-up, this which is good for you. Okay. Thanks
yeah.
the
Thank you.
audience. Yeah.
We have already have a cardiologist appointment as well.
Okay. Okay, thank you. And how methylprednisolone will help this situation? I think Hussein answered this question already. And how long we can give oral prednisolone or hydroxychloroquine? So the question is how long? Is it the lifelong one or with, yep.
Yes,
So,
you can do that.
yeah, so the lifelong one, right?
Yes, you can do. You know, this is a genetic disorder. So the background of the pneumocyte type 2 could not be able to produce more surfactant C as the normal level that needed for the expansion the alveoli. Such patients suffer from the many virus infection that flare up all the problem again and again. So we have to reserve the pulse of methylprednisolone mostly for the severe time. And then we can continue with the oral sometimes in the maybe every other day, or sometimes like 2 or 3 times per week. And also you can choose the nebulizer type of budesonide, also make in some patient a very good result. But this need, this is a need the decision for every patient by patient, for this, because this is no more, and this is actually a very rare disease, and no more information in the literature. Many of the doctor treat them as their experience. So for this type of patient, we have to continue the patient to grow up until they give a chance for the lung transplantation, because protein C make more and more with the flare up the infection and become more cystic lesion, and all of the line become more cystic in the next future. So you could give the patient the chance for the grow up for the transplantation.
Okay, so thanks a lot. Okay, so we run out of time right now. There is the comment, very good comment one, that if the PAS positive, surfactant protein C deficiency can cause the alveolar proteinosis as well. So if the PAS positive, we need to do the whole lung lavage. And Dr. Rini asks, what should we monitor if we give pulse methylprednisolone for the baby? Yeah, I think we almost ran out of time. Would you like to answer this question about how to monitor the patient on pulse methylpred? Maybe Daniel, please.
I think you can monitor from the lung function, which is basically the oximetry. Basically clinically and oximetry, and if you can, the lung functions, infant lung function for the lung volume, the raised lung volume, and of course radiologically.
Okay, thanks. Yeah, there is a question. Do inhaled corticosteroid can be used alternate to oral steroid? I thought Ashkan answered already. And another one is lipid-laden macrophages is a poor test for aspiration. If you are thinking about reflux in a major way, we can do the impedance test. Yes, I do agree with that. Yeah, and more audience agree with that comments as well. Okay, and can it be confused with hypersensitivity pneumonia? That's an interesting question. In UK or Europe, we follow this reference. There is some reference to reduce the dose for infants. Yeah, thanks. So the audience can follow in the chat box. There is a link to the PubMed, which is very good one, and even have the table of the dose medication to be used in the clinical response in the child, in the children with the ILD, ventilated or not ventilated. Thanks a lot. That's very informative one. Yeah, I like the atmosphere of this first grand round, but unfortunately, I think we ran out of time. May I ask Professor Arunwant Prutipan, our president of the APPS, to conclude this session, please?
So I like hopefully everyone enjoy this session a lot, and I think we can share experience and knowledge, and also sharing the resource on each country as well. So I would like to end this session by thanks the panelists who volunteer to do this job, and also the moderator and the presenter, and the next APPS meeting, the next APPS Grand Round will be on the 23rd of February and run by our Indian colleagues who leaded by Professor Valinder Singh. So hopefully we will see you again next month on the last Friday of each month, and we have 13 countries in the row to see you. Thank you so much and see you.